Now, a very important swelling that is rare but it may be encountered in our in clinical practice is a neuroma. Neuroma arises in relation to the nerve fiber. It can be a true neuroma or it can be a false neuroma. True neuromas are exceedingly rare. A very important example of a true neuroma is a ganglioneuroma. So it arises from the sympathetic ganglion and it is a benign tumor. Another example for a true neuroma is a myelinic neuroma. Myelinic neuroma arises from is commonly seen in the spinal cord and arises from the pia mater. False neuromas occur following injury to the nerve, either by trauma or during surgery. And there are two important types of false neuromas. One is an end neuroma, another one is a lateral neuroma or a side neuroma. So an end neuroma is very common following amputations. For example, if you have an amputation, a below knee amputation, the nerve fibers which have been amputated along with the rest of the tissue can undergo proliferation. The tip can undergo proliferation, forming a swelling which is firm to hard, tender, and might interfere with the fitting of a prosthesis. So to prevent this during an amputation, we tend to stretch the nerve and cut it proximally so that it retracts, the end retracts away from the cut edge of the wound. Now, a lateral neuroma occurs following a partial injury to a nerve, commonly a peripheral nerve. So these lateral neuromas usually again occur, like I said, following a partial injury. So it occurs on the side of the nerve fiber. Again, it can be associated with pain and paresthesia. And characteristically, these neuromas, lateral neuromas particularly, they move transversely or perpendicular to the long axis of the nerve. Fibromas. When you have fibrous tissue becoming encapsulated and forming a swelling, it's called a fibroma. Again, like in a neuroma, it can be a true fibroma or a false fibroma. A true fibroma can be hard or can be soft. If it has immature fibrous tissue, it is usually a soft true fibroma, and it is commonly seen in the face. When you have a hard true fibroma, it is usually seen in the palms and soles and contains mature fibrous tissue. There is an entity called aggressive fibromatosis, which is wherein the fibroma is unencapsulated, commonly seen in the chest and the abdominal walls, can be little deep-seated, locally very aggressive, can attain large sizes, and because of this locally aggressive nature, following excision, there is a very high chance it can recur. But these are non-metastatic because they are not malignancy. Desmoid tumors can also be said to be a fibroma, particularly commonly seen in females with Gardner's syndrome. Now, recurrent fibroid of Paget is an important condition which is basically a fibrosarcoma arising from a scar tissue after many years. Now, no topic on fibromas will be complete without covering this particular swelling called a neurofibroma. A neurofibroma is a benign tumor arising from the connective tissue of nerve fibers containing ectodermal and mesodermal components. Ectodermal component is usually the neural component and the mesodermal component is a connective tissue component. They can be single or they can be multiple in nature, can be associated with pheochromocytoma and hypertension. So these neurofibromas can occur in the peripheral nerves, can be intracranial, can be spinal as well. In fact, spinal neurofibroma is the most common intradural extramedullary spinal tumor. There are different types of neurofibroma. We have the nodular neurofibroma, the plexiform neurofibroma, the generalized neurofibroma, lymphatic neurofibroma, and cutaneous neurofibroma. So nodular neurofibroma are typically single in nature and they are extremely tender. So these swellings tend to move horizontally or transversely in a direction perpendicular to the direction or perpendicular to the long axis of the nerve fiber. So they move in a horizontal direction, horizontally in a direction perpendicular to the long axis of the nerve fiber. And there is typically pain and paresthesia all along the distribution of that particular nerve. Plexiform neurofibroma commonly occurs along the fifth cranial nerve. There is increase in size and thickening of skin along the area of distribution of this nerve with associated erosion into the bone or orbit. Myxomatous degeneration is again very common with plexiform neurofibroma. Paresthesia can occur all along the distribution of the trigeminal nerve. There is a variant of plexiform neurofibroma called a pachydermatocele, wherein there is involvement of the neck. Generalized neurofibroma, von Reckling-Hansen's disease. Now, generalized neurofibroma has an incidence of 1 in 4,000. It is autosomal dominant. There are two types of generalized neurofibromatosis, as it's commonly called. Type 1, wherein there is involvement of chromosome 17, and in 50% cases it's familial. Type 2, wherein you have involvement of chromosome number 22. Type 1 neurofibromatosis, generalized neurofibromatosis, is called von Reckling-Hansen disease, whereas type 2 disease is called acoustic neurofibromatosis. There is characteristic presence of pigmented spots, usually in the back, called cafe au lait spots. Presence of more than 5 cafe au lait spots, and each more than 1.5 centimeters in size, is a pointer towards generalized neurofibromatosis. But the problem is, presence of cafe au lait spots does not occur only in neurofibromatosis. It can occur in another condition called McCune-Albright syndrome. Axillary and groin freckles are common features of neurofibromatosis. Leash nodules in the iris, again a typical feature of neurofibromatosis. It can be associated with other conditions like pheochromocytoma, medullary carcinoma of thyroid, and constitute what is called as multiple endocrine neoplasm type 2B. Cutaneous neurofibromatosis are usually small and multiple, occurring at the end of dermal nerves. So they can occur all over the body, can be pedunculated or sessile. When it occurs in the scalp, it has a characteristic turban-like appearance, leading on to the terminology turban tumor. Common complications associated with neurofibromas are basically cystic degeneration. When it occurs within the spinal cord, it can cause compression of the spinal cord, can cause neurological deficits. And this is also common when you have a dumbbell tumor, which you have an extraspinal and an intraspinal component. Again, it can cause symptoms. Erosion into deeper planes are known to occur with neurofibromatosis, particularly, like I said earlier, plexiform variant. Sarcomatous changes can occur, which is characterized by a sudden increase in size of the swelling with increased vascularity or dilated veins of the swelling, pain, and erythema. Now, surgery as far as surgery is concerned in neurofibroma, indications are if the lesion is symptomatic, if it's cosmetically problematic, or if there is malignant transformation, which occurs in 5% cases. An important differential diagnosis for a neurofibroma is a Neurilemmoma. So what is a Neurilemmoma? It's also called a Schwannoma. It arises from Schwann cells. Characteristically, these are lobulated, well-encapsulated, soft whitish grey, soft swellings with a whitish grey appearance. They commonly are seen in the cerebellopontine angle in association with the acoustic nerve. These are usually have an important problem or sequelae of schwannoma is that these have calcification. And differentiating a schwannoma from a neurofibroma is by the fact that schwannoma is mobile in all directions, whereas a neurofibroma, like I said earlier, might be mobile in a direction perpendicular to the long axis of the nerve. Schwannomas are ectodermal in origin, and there are two important types of schwannomas, basically Antony A and Antony B. So Antony A, there are two rows of spindle cells with an acellular area in the center called Verroque bodies. Antony B has acellular myeloid areas. So like in the case of a neurofibroma, even a schwannoma can cause pain along the distribution of the nerve, hyperesthesia, and localized tenderness. Then, like I said earlier, these swellings are mobile in nature, mobile in all directions. Now, even though they might be closely associated with the nerve, usually they can be separated from the nerve pretty easily. So, excision of these schwannomas can be done with minimal damage to the nerve it is associated with. If you have a recurrent schwannoma, always be careful, it could be a malignancy. Ganglions. So ganglions are cystic swellings which arise within a tendon sheet, synovial sheet, or from a joint capsule. They have a clear gel-like fluid and are commonly seen on the dorsum of the wrist, near the scaphoid and lunate articulation. They can also be seen on the flexor aspect of the wrist, or it can be seen on the hands as well, around the ankle joint, where it is pretty rare. And the common reason why a ganglion occurs is because of either a cystic degeneration of the tendon sheet, or because of leakage of synovial fluid from the joint capsule through the joint capsule, or when small islets of microspaces in the synovial sheet fuse together, or one of them becomes increased in size to form a cystic lesion. These are smooth, cystic, characteristically non-tender swellings which have transillumination. So this here you can see that a transillumination tests positivity in a person with a ganglion. Occasionally it might communicate with the joint capsule. Now it might have pain, tenderness and restricted joint movements. A differential diagnosis for a ganglion is a lymph cyst or a bursa. Now treatment. Now one very important factor which actually influences treatment with regard to ganglion is its notoriety to produce recurrences. Excision of a ganglion is associated with 30% chance of recurrence. So there are certain schools of thought, people who say that a small ganglion which is asymptomatic, we better observe it. But now the dictum is that we can go ahead with injection sclerotherapy, injecting hyaluronidase along with the steroid. Papilloma. Now papillomas are warty swellings which can arise from the skin or from the mucous membrane. Generally it has a central axis. It has a central axis like you can see here, which contains the blood supply to the papillomatous lesion. So a papilloma can be a true papilloma or a false papilloma. A true papilloma is a benign tumor wherein there is overgrowth of all layers of the skin. They can be pedunculated or rarely may be sessile in nature. They contain sweat glands, sebaceous glands and hair follicles. A true papilloma can be cutaneous or it can be mucosal. A cutaneous papilloma can again be squamous or basal. Squamous papillomas are usually soft in nature, occurring in the eyelids of elderly individuals. A basal papilloma is usually oily semi-transparent, commonly seen in the trunk of elderly individuals. In true papilloma, there is a propensity for malignancy, and the malignancy is usually squamous cell carcinoma. In the breast, duct papilloma is the most common cause for bloody discharge from the nipple. Mucosal papillomas, these are all cutaneous papillomas. So mucosal papillomas can arise from the oral cavity, bladder, rectum, larynx, gallbladder, etc. Treatment of an papilloma would involve excising the lesion with a 1 cm skin margin. Complications commonly associated with papillomas are bleeding, malignant transformations, ulceration of the summit of the papilloma, mechanical disability, especially if it is located within luminal structures, for example, like the larynx, etc., bladder, larynx, etc. Fibroepithelial papilloma are basically skin tags with a size less than 5 mm. If it is a cosmetic problem, you can go ahead with excision. Papillomas can also be infective in nature. Commonly, it's called condyloma acuminata, which would require excision or carbon dioxide snow or diathermy. So this is a clinical image, a post-excision image of a papilloma. A very important condition which might mimic a papilloma would be a wart. So wart are usually multiple hyperkeratotic skin patches with finger-like projections. They are commonly flat, sessile in nature, might be pedunculated also. Commonly associated with human papillomavirus infection type 2 and 4. Involving fingertips, face, axilla and sole of foot, these usually transmit from one surface to another by repeated rubbing, and hence they are called kissing lesions. Plantar warts. Plantar warts are characteristically, you have இந்த ஸ்லைட் திருப்பி ஸ்டார்ட் பண்றேங்க. So warts are basically multiple hyperkeratotic skin patches with finger-like projections. They are associated with human papilloma virus type 2 and type 4 infections. It involves fingertips, face, axilla and sole of foot. It is generally transmitted from one surface to another in the same person or from person to person by repeated rubbing. So hence they are called kissing lesions. Plantar warts are characterized by the presence of a deep-seated wart with only manifest outside by a small pit. It is because of constant pressure and it is seen in the sole. They are extremely painful and tender to touch. Butcher's wart or pathologist wart or verrucous neurogenica is basically a Mycobacterium tuberculosis infection wherein the organism enters through broken skin. It is usually seen on the dorsal aspect of the hand. Warts can be senile or venereal in nature. Treatment of warts would involve usage of salicylic acid, podophyllin cream and laser ablation or excision. Gangliangioma or glomus tumors as it's called. So basically it arises from a cutaneous glomus wherein a tortuous arteriole communicates directly with a venule with surrounding close proximity to a lot of nerve fibers. So this communication is called Sackett-Hoyer canal. So these glomus tumors or glomangioma as it's called is extremely painful, occurring in the nail beds. It's also called an angiomyoneuroma because it contains a vascular component, a neural component and a muscle component which is basically the wall of the blood vessel. Typically they are small in size with a size of 2 to 3 millimeters and these have no malignant transformation. The main complaint of patients who present with these glomus tumors are pain. The pain is actually relieved when you apply a BP cuff over the limb involved, and when you raise the pressures or you inflate the cuff beyond the systolic blood pressure, then the pain of the glomus tumor tends to subside. Exposure to low temperatures can increase the pain associated with the swelling. These swellings or these lesions are typically reddish blue in nature and they are non-blanching. Excision is required if pain relief has to be obtained. Bursa. Now, a bursa is a sac-like cavity which contains fluid within it. It can occur in normal locations around joints to prevent friction between the tendon and bone. These bursas generally have a good endothelial or epithelial lining which secretes a synovium-like clear fluid. Usually this fluid is very minimal and when there is irritation of the membrane lining these bursa, it produces an increased amount of fluid and becomes clinically manifested. So the cause for irritation can be trauma or infection. When you have an infection or an inflammation of a bursa, it's called a pathological bursitis. A long-standing bursitis, the skin tends to become thickened, hard, gritty, calcified. In such cases, these bursa can be adherent to the skin and deeper tissues. They might communicate with the joint cavity and can have associated joint pathologies like gout or rheumatoid arthritis. So management of bursae would involve doing an ultrasound or an MRI to assess the extent of the bursa, avoiding friction and other aggravating factors. Aspiration and sclerosing injection can be tried. Excision can also be attempted. There are two important types of bursa. One are anatomical bursa, another one is adventitious bursa. Anatomical bursas are basically normally located bursas which are located in their normal locations. For example, commonly around the elbow joint, around the knee joints, around the ankle, etc. So these bursae tend to get inflamed, infected, leading on to bursitis. So when you have an bursitis involving the olecranon bursa, it is called a student's elbow or a miner's elbow. It is because of the tendency of students to sit like how I am sitting with my elbow rested against a table. When you have a prepatellar bursa inflammation or bursitis, it is called as a housemaid's knee or a miner's beat knee. Inflammation of the infrapatellar bursa can result in clergyman's knee. Bursa anserina is basically located under the tendons of the gyrobes, which is basically the four important muscles, which is semitendinosus, gracilis and sartorius. Under the tendon of these muscles, you have the bursa anserina. So this here is a clinical image of a person who presented with a prepatellar bursitis, okay, which is called as a housemaid's knee. So these prepatellar bursa is typically located superficial to the patella and deep to the skin. And this is a person with a clergyman's bursitis or an infrapatellar bursitis. And this clergyman's bursitis, infrapatellar bursitis is basically inflammation of the bursa located below the patella, deep to the skin and superficial to the tibial tuberosity. Adventitious bursas are bursas which are not anatomical in their location. Basically, they are not supposed to be there. They are unusual sites of bursa location. They occur because of constant friction or pressure between two layers of tissues. Infections are very common in adventitious bursa, calcifications, and the fluid might become thick. They are usually non-tender, but if they are infected, they tend to become tender in nature. Because it contains fluid which is thick with a lot of fibrinous material inside, they have a typical grating or a grating sensation or a crepitus. A common example for an adventitious bursa is a bunion, which is basically a bursa which is located at the head of the first metatarsal in people with a hallux valgus. So it is located between the head of the first metatarsal and the skin. Another type of adventitious bursa is a Taylor's bursa, which occurs between the lateral malleolus and the skin. Potter's bursa, wherein it occurs between the skin over the shoulder and the medial end of the clavicle. Weaver's bursa, which occurs between the gluteus maximus, ischial tuberosity and the skin. So these are few examples of a adventitious bursa. Now, there are certain adventitious bursas that we need to know about because it can be seen in individuals who are athletes. For example, like subcalcaneal bursitis, wherein you have a bursa located between the calcaneum and the heel, which occur in long distance runners. Now, an interesting adventitious bursitis is a Billinggate hump. A Billinggate hump generally occurs at the base of the neck, superficial to the 7th cervical spine, deep to the overlying skin. It is because of constantly carrying weight over the region. Now, Billinggate is the name of a famous fish market in England. Following the diagnosis of a bursitis, it is very important that we go ahead with an X-ray of the part to rule out any associated bony anomalies or joint anomalies and an FNAC of the swelling, following which we can go for an excision. Semimembranous bursa. The reason why we are going to discuss the next two bursas separately is because these are more common than the others and these have typical features. A semimembranosus bursa typically occurs in the upper medial aspect of the popliteal fossa. You can see here. It occurs under the semimembranosus tendon and typically it is above the knee joint line. It is the most common swelling of the popliteal fossa and it is typically transilluminant. There is no joint communication, but on flexion, the lesion might become a little flaccid because of redistribution of the fluid into deeper planes. Ultrasound of the popliteal fossa can help us in clinching the diagnosis of a semimembranosus bursa, and excision is the treatment of choice. The more famous cyst of the popliteal fossa is the Morrant-Baker's cyst, which is a cystic swelling located in the lower midline region of the popliteal fossa, below the knee joint line. There is herniation of the synovial membrane of the knee joint. Hence, it is commonly associated with underlying knee pathologies, including rheumatoid. It is a pulsion or a pressure diverticulum, and these are typically non-transilluminant. These lesions disappear on flexion of the knee because they communicate with the joint cavity, and they can present with knee joint pain, tenderness and effusion. A ruptured Baker's cyst can present with severe sudden onset calf tenderness mimicking a deep vein thrombosis. X-ray and MRI of the knee joint can clinch the diagnosis and can also give us an idea regarding an underlying joint pathology. Excision of the cyst is typically done in the prone position. Lymphangiomas. Congenital clusters of dilated lymph sacs which fail to join normal lymph system result in the formation of a lymphangioma. There are different types of lymphangiomas. For example, like a capillary lympangioma. These are present at birth and manifest themselves as skin vesicles. And these vesicles contain clear fluid, but over a period of time, there can be some hemolysis, some collection, resulting in these vesicles becoming discolored and having a more blackish brown appearance. Very commonly seen over the shoulder, axilla, groin and buttock. When you have a lesion which is less than 5 centimeters in size, these are called lymphangioma circumscriptum. If the lesion is more than 5 centimeters, it's called lymphangioma diffusum, and if the lesion has reticulated edges, it's called lymphedema ab igna. Typically, there is no block to the lymph drainage to normal areas, there is no skin edema, there is no localized or generalized lymphadenopathy. Cavernous lymphangioma is basically presents itself as a lobulated, brilliantly transluminant swelling which extends into deeper planes, particularly muscles. Very commonly seen in the face, tongue, lips and mouth. Tongue lymphangiomas are usually cavernous lymphangiomas. Cystic hygroma. Cystic hygroma basically is a collection of clustered, sequestered lymph cysts or lymph sacs which do not communicate with the major lymphatic system. So they present as soft, fluctuant, brilliantly transluminant swellings which are compressible, commonly noticed in the cervical region or in the axillary region. So this is a cystic hygroma showing brilliant transillumination and it is usually compressible. A very important thing to be noted with regard to cystic hygromas and other lymph cysts is that they have pseudopodal extensions into deeper tissues. So unless it is excised in toto, there is very high chance of a recurrence with regard to a lymphatic cyst. Calcinosis cutis. So calcinosis cutis is basically calcification which is located in or under the skin. Very commonly seen in females, usually around the waist on either side. It occurs because there is friction and there is degeneration of the skin and underlying tissue. This produces a localized alkalinity wherein there is deposition of calcium. The most important line of management as far as calcinosis cutis is concerned is that it should be excised. The problem with excision is that if it is extensive, you might require a flap cover. So this is a clinical image showing calcinosis cutis involving the finger and is an X-ray showing extensive calcification. Chordoma. Now chordoma is an exceedingly rare tumor, slow growing tumor arising from the notochord. It can be classical, chondroid and dedifferentiated. It is usually seen in the sacrococcygeal region, sphenoid sinus or from the foramen magnum. So this here is an MRI image which is showing a presacral mass arising from the sacrococcygeal region, which is a chordoma. It is locally invasive and the treatment of choice is to go ahead with a wide local excision. Radiotherapy has very little role as far as chordoma is concerned, but then providing highly focused proton or carbon ion radiation might help. So epignathes is an exceedingly rare swelling seen commonly in newborn children, wherein there is a growth on the base of the skull which protrudes through the mouth. So with this we come to the end of this topic, basically swellings. So all these information have been taken from XRB's textbook of or manual of surgery, 6th edition. So I would like to reiterate that this topic is particularly important from the clinical as well as from the theoretical point of view, and a good knowledge of these swellings theoretically can aid us in the clinical examination as well. So until we meet the next time, thank you.